introduce you in the first lecture, that is deep vein reconstructive surgery, an overview. Please, Oscar, thank you.
So we will see an overview on deep vein reconstructive surgery. And which role does deep venous reflux play in chronic venous insufficiency? And when should it be corrected? Deep venous surgery is aimed at the treatment of chronic venous insufficiency, particularly in patients in class C4b, C6. And compression therapy, we know that can heal ulcers, but is associated with a high rate of recurrence. In the advanced stages of the disease, deep venous insufficiency is associated in 2/3 of cases with superficial insufficiency and or perforators, and by eliminating superficial reflux, we can improve a certain percentage of patients, but not at all. In fact, the recurrence rate is particularly high, and this shows the importance of deep venous system reconstruction. This has been known for many years. Linton believed that abolishing reflux was essential even at the cost of tying up the main axis. Venous obstruction was considered a secondary and infrequent factor, for which the real reconstructive surgery of the deep venous system was born late, exactly in 1968, the date in which Kistner performed the first valvuloplasty. Valvuloplasty can be performed when the valves are present but malfunctioning. This is due to mostly concomitant defects, including the asymmetry of the cusps. It is rare that the valve is saved after a thrombosis. It is possible after a thrombolysis. And in these cases, if the damage is slight, it can be repaired. In most cases of deep venous thrombosis, only anticoagulant therapy is performed and the valves are damaged beyond repair. Since this is the most frequent etiology, efforts have been concentrated around it. Among the many proposed interventions, 3 are currently mainly used: vein transposition, vein transplant, and new valve. Transposition, it consists in rotating the axis with reflux by connecting it to a nearby axis with the valve. This creates a new main axis with 1 or more proximal valves. Valve transplant consists of inserting a segment of vein containing a valve into the reflux axis. Usually a segment of axillary vein is inserted at the popliteal level. Third possibility is the neovalve, which consists of a dissection of the wall with the aim of creating a flap. It can also be performed in the rare case of valvular agenesis, but is very difficult due to the absence of wall fibrosis. Other techniques such as external valvuloplasty or bending are almost abandoned. You see above an old PTFE bending completely crushed by the fibrotic reaction. What result has deep vein surgery achieved over the years? The patency results are satisfactory, both in primary, that in secondary post-thrombotic syndrome. very rare case of pulmonary embolism, good results of valvular competence in primary, lower but still satisfactory in post-thrombotic syndrome, satisfactory results for symptoms, and for edema, even if this is the most difficult sign to correct. More satisfactory results for healing ulcers. Over time, however, we have a recurrence of ulcers, especially in post-thrombotic syndrome, and this is because the patient with post-thrombotic syndrome cannot be abandoned in his course. In conclusion, there are safe techniques that can provide good result. The result of surgery in post-thrombotic syndrome deteriorates over time, which is why its diffusion has decreased over the years, despite the fact that many techniques applied in the arterial field obtain much worse results over time. Attention was drawn by the introduction of the new valve. However, in the same year, deep vein obstruction was taking on an important role, and not only reflux. Concept that took on a preponderant role with the publication of this work, in which it was described how approximately half of the patient can obtain healing of the ulcer having the deep venous reflux unchanged. This didn't make Michel Perrin very happy. Finding myself between the two contenders, I did a study with Marcia that showed that what Neglen said was true, but there were still 50% of patients who could be improved later with the correction of the reflux. And that made Michel happy again. Now venous obstruction is treated aggressively, but only improves half of the cases. What are the concepts that guide deep venous surgery today? Chronic venous insufficiency is correlated with hemodynamic disturbances related to obstruction and reflux. Both are responsible for microcirculatory disorder that lead to symptoms and signs, and the two hemodynamic disorders are associated in 2/3 of cases. Therefore, surgery of deep venous system must be addressed to the treatment of both. In this way, 50 of the patients will improve their clinical condition without treating the reflux. The treatment of choice is angioplasty stenting, but in several situations there is the presence of obstruction with excessive fibrotic material at the level of common femoral artery or at the popliteal level. It is necessary to perform an endophlebectomy since it is not possible to distend the stent. Angioplasty and stenting associated with endophlebectomy hybrid procedure represents a widely used technique, especially in case of obstruction related to the use of drug injected into the femoral vein. Direct surgery of iliac caval tract is currently limited to neoplastic pathologies or cases that cannot be treated endoluminally and which decompensated limb. It is necessary to consider reconstructive surgery of deep venous system when the quality of life is compromised and both conservative and superficial system directed treatments are no longer able to allow an acceptable quality of life. Reflux surgery must be carefully considered and performed by expert teams and after an accurate diagnosis, and it is essential to apply a rigid diagnostic protocol, and in patient with post-thrombotic syndrome who has an indication for treatment, diagnostic protocol will be applied to evaluate superficial and deep system. And in case of significant axial superficial reflux, this will be corrected in an attempt to obtain improvement. In case of identified obstruction, we will proceed to correct it, and only in case of failure will we think about correcting of reflux. If no obstruction are detected and superficial system does not play a significant role, the most suitable technique for correcting the deep reflux will be evaluated. As for the future, what awaits us? We need studies capable of establishing a correlation between symptoms, signs, and hemodynamic causes. We need to obtain information relating to normal walking. And we need to make correlation between hemodynamic damage and the scores. We need venous substitutes with low thrombogenicity to be applied when endophlebectomy is not feasible. We need implantable valves with low thrombogenicity and long life. All this because post-thrombotic disease will increase, and we know that the treatment of the deep venous system significantly reduces the social cost of the disease. Thank you very much.
Thank you, Dr. Maleti. Okay, the next is a valvuloplasty in primary insufficiency. Dr. Silva, please.